Thank you, Mr. Chairman, for the introductions. Good morning, everyone. Uh, Thank you for joining the BUU 2021 on prostate cancer sessions. I am Dr. Teh, and I've been tasked to give you short lectures on the management of early prostate cancer. When we come to managing of early prostate cancer, there are two key factors we need to take into considerations. One is the patient, the other one is the cancer. Now, after you consider the factors that is affecting the patient longevity and as well as survival, then you look at the cancer aggressiveness. That will decide what are the treatment options will be appropriate for the patient. So the outline of my today's talk will first to highlight 3 points. One is the concept of life expectancy and natural history of prostate cancer. Second is to how risk stratification of localized prostate cancer affect the treatment option. And finally, we will look at the various treatment option for localized prostate cancer. Prostate cancer can present in a various way, as you have listened to the previous speaker. In early localized prostate cancer, typically the presentation is asymptomatic and is a incidental finding of abnormal DRE or an elevated PSA. And in locally advanced cancer, which is non-metastatic, not uncommon, you will see lower urinary tract symptom as AUR or upper tract dilatation. While metastatic disease tends to have a systemic effect on the patient. The incidence of prostate cancer in autopsy series has been well studied over the last century, in fact, and we have up to 50 over 1,000 patients in the autopsy series, as is reviewed in this latest meta-analysis on the autopsy series. As you can see, the cancer, incidental prostate cancer autopsy, patient die of other causes other than prostate cancer, increase with age, but it's nowhere reached the common dictum saying that 90% of the men prostate cancer when they reach age of 90. It's still hovering around 50%. So these are the factors. So knowing that it's such a common disease, then you come to look at the mortality rate of clinically important prostate cancer. The cancer mortality rate is far lower as compared to the prostate cancer prevalent rate detected in the autopsy series. Second is about the concept of life expectancy. This table you can easily download it from the WHO website. On the International Global Can website today. And in Malaysia, the life expectancy of a 60 to 65 years old man is average and around in the range of 18.5 years old, and that will slowly reduce. And when you reach the age of 70 to 74, the age is life expectancy is around 12 years. So in accordance with the, you can see when you have a patient sitting in front of you, that will be a determining factor as to what you want to do or the patient want to do with the newly diagnosed prostate cancer. As we all know, early prostate cancer have a long clinical course before it reaches metastasis and even causing death in the patient. So I give you a clinical scenario of Mr. X, who is a 65 years old man who is relatively healthy beside hypertension. And he has a non-significant past medical history, except that he has a bilateral inguinal hernia repair 10 years ago. He has a PSA of 5.6, and his recent score come from the prostate cancer biopsy is a 3+4 in 2 out of 12 core standard biopsy. He has an MRI, show a PIRA2 lesion in the right TZ, and there's no other high PIRA lesion detected in the prostate. So how will you manage this patient from this point onwards? So Mr. X would like to know, if you do nothing, what will happen to him? So if Mr. X don't do anything, just live with the prostate cancer, in 10 years' time, 100 men of his similar situation, out of the 100 men, 27 will have died. And out of these 27 deaths, 9 will be from prostate cancer, while the other 18 from non-prostate cancer related death. And if that goes straight to 15 years, then 14 out of the 100 men who have similar clinical disease like him will die from prostate cancer left untreated. I think this is a much easier scenario for the patient to make a decision as to how he wants to do with the disease that's facing him at that moment. We'll come back to Mr. X later on when we discuss about the active treatment. Another important concept in the determining of life expectancy is the geriatric screening and in terms of fitness of the patient to undergo procedure. So in this particular last few years, in fact, EAU and many of the major associations has come up with guidelines to take into consideration geriatric screening for patients who presented with early prostate cancer, because prostate cancer typically affect men of 60 years and above. So if you have a fit older man with a chance of living more than 10 years with prostate cancer, according to the D-amical risk classification, then you are most likely to benefit from it. You have an intermediate or high risk disease that you treat active. So it's called this G8 and the mini-COP assessment. I would not want to go into the detail of that, but suffice to say is that if you screen them with G8 and mini-COP, then you categorize them into basically three groups: fit group and the frail group and some sort of group 2 who is vulnerable. Vulnerable means that you need to have some optimization to move the patient into group 1. So group 1 and group 2, you can offer them definite treatment. Well, group 3 is frail. Most appropriate treatment will be water-witty or no active intervention in this particular group of patients, even in early prostate cancer. So EAU is very clear on this, and it has a very strong recommendation for using the G8 and mini-COP to assess patient, as well as frailty scale score in the overall assessment of the patient health status in deciding what to offer the patient. So with that, after you assess the patient, then you need to look at the cancer itself, the biology of the cancer. And the last few years, I think increasingly germline testing and somatic genetic aberration has come into play in the clinical assessment of the patient with prostate cancer. So you should consider germline testing if the patient have any of these features. For example, presented with upfront metastatic prostate cancer happening at a younger age, less than 60, with a strong family history of prostate cancer, as depicted on the slides. So one of the very important features in managing early prostate cancer is to risk stratify the patient. You need to stratify them into low risk, intermediate risk, and or high risk patient based on PSA, BRE finding, and as well as the biopsy grading of the prostate cancer. One of the important key point I want to highlight is regarding the T stage is solely based on BRE finding. It's not based on the biopsy finding. I give you a very practical advice that if you have a T1C by finger examination, you biopsy and the biopsy come back both sides of cancer, patient is a T1C, not a T2C disease. So T means the palpable nodule and clinical involvement of both lobes or one lobe or more than 50 or less than 50% of unit. So for treatment of localized prostate cancer, so first you consider the tumor stage. If you are locally advanced or not locally advanced. Locally advanced means T3 and above. So those cancer, typically you must treat them with active treatment, whether it's a radiotherapy or radical prostatectomy. Whereas in terms of risk stratification, we have gone through it in the previous slides. And in a nutshell, is that low risk disease, it can be treated with active surveillance as the default treatment option. Meaning that the patient cannot accept that, then you move on to discuss about radiotherapy or radical prostatectomy. Whereas for intermediate risk and high risk disease, the default treatment should be active treatment in the form of either radiation or radical prostatectomy, taking into consideration of patient preference in terms of sexual function, urinary function, and acceptability for them for surgical intervention. So importantly, I think for early localized prostate cancer, ADT monotherapy should never be offered for patients with non-metastatic disease in this setting. So patients should be either fall into water waiting with no active intervention if they decline any of the treatment option. So as you can see on this pie chart is to show that the trend of managing prostate cancer across various age groups in US published in the American Cancer Society recently. So as you grow older, the aggressive you tend to adopt more active surveillance, as shown in the orange pie. When they are patients above 60 to 75, more than half will have adopted active surveillance. Whereas when you are younger patients, 65 and below, radical prostatectomy is the preferred choice of treatment for local control and also for because of the long longevity of the patient. So active surveillance, the rationale for it is that because we know the natural history of the prostate cancer mainly is driven by the pathology and the genetic aberration. Absent of all those aggressive features, then we know reason 6 rarely metastasize and rarely progress. So the default treatment for low-risk disease should be active surveillance. But one of the important pitfall or shortcoming of this is called misclassification, meaning that patients actually have a higher grade cancer, but for some reason the biopsy only managed to detect the 3+3 lesion. So that's why when you have active surveillance, you need to have an active monitoring, repeat scan, and maybe biopsy, and also have monitoring of PSA on a periodic basis. So the differences between these two options of not giving active patient at the point of diagnosis is depicted on this slide. You can see watchful waiting is palliative, and they do not do regular imaging for the patient until the patient develop basically symptomatic progression or symptomatic metastasis. Then you treat accordingly. So the outcome of watchful waiting for patients with early localized prostate cancer has been studied in this SPCG trial, randomized control trial compared in the placebo arm, or so-called watchful waiting arm. You can see disease-specific mortality up to 23.6-year median follow-up is 31.3%, meaning that 70% will die of prostate cancer of the mortality. So, but overall mortality is 83.8%, still about more than half of patients with early untreated prostate cancer will die of other disease, although half of them will develop metastatic. But you still will treat the metastasis when they develop under the watchful waiting arm. So active surveillance had a very good outcome, and many series have shown its safety in practice. So you can see 10-year overall survival and 10-year cancer-specific survival is well above 90%. I think this is very acceptable for elderly population that we are facing, and seeing this data is quite reassuring. I wouldn't go into the specific trial, but suffice to say is that from cross trials, up to 16 years, you can see the cumulative mortality, most of the patients will die from non-prostate cancer death as compared to prostate cancer death. So this again is a very well-known phenomenon in a patient with early prostate cancer with the low Gleason's grade as well as low PSA. So in consideration for active surveillance, you look at your patient, you look at clinical, and you look at the pathology. Your patient mustn't have any of these unfavorable pathology variant, which will signify likelihood of under or misclassification or more aggressive disease, which may have misclassified as a low-risk disease. So the protocol I have mentioned in the earlier, so in the summary is that you regularly check the PSA every 3 to 6 monthly, and you do imaging when the PSA rise. Typically, it's the MT-MRI to look at the development of the new period lesion. So you do not need to do any bone scan or CT scan for low-risk patient practically. So protocol-based biopsy is still debatable. There's no concluding evidence to support its use. So, but the patient will move on to active treatment if they refuse any further imaging or biopsy, or the PSA doubling time is less than 36 months, or MT-MRI show any of the evidence of new higher pilot lesion, or biopsy show higher rate of cancer for that matter. And anxiety certainly is one of the justifiable trigger for prostate to move on to active treatment. So I think the debate on the safety of active surveillance has been settled by the level 1 evidence through this randomized control trial from the PROTECT trial, clearly show the safety of prostate cancer death as compared across the 3-arm active surveillance, radiotherapy, and radical prostatectomy are equivalent. Although those choose active surveillance have a higher rate of metastasis, but the absolute number is small, and the clinical progression rate is also double of the radiotherapy or radical prostatectomy arm. So, but the bottom line, the most important thing in terms of death is equivalent. So then we move on to what we surgeons or urologists think we do the best, called radical prostatectomy with or without pelvic dissection. Many discussion and controversy in terms of surgical technique, nurse sparing, all these things will be been discussed, but I would not bring this topic into the discussion for this group of audience because I think they are way beyond the 20 minutes allotted to them. But the same patient that we see earlier on, you can see, if you subject the patient, you want to subject the patient to radical prostatectomy, you should try to predict what is the outcome likely to be based on a nomogram from the Memorial Sloan Kettering pre-radical prostatectomy monogram by entering the various variables that the patient had in the earlier slide I showed you. So based on his clinical information, then the patient have a probability of cancer-specific survival after radical prostatectomy is way above 99% in 10 or 15 years, quite similar to PROTECT trial. And the progression-free probability after radical prostate is 88 and 80% respectively at 5 to 10 years. So meaning that you don't require any additional treatment. Very likely monotherapy will adequate for him 80% of cases up to 10 years. How about do you need to do lymph node? In this case, you do not need to because the lymph node involvement rate is around 2%. So less than 5%, we do not conduct lymph node dissection in this particular patient. So this is a very useful tool for us to do it. So in terms of pre-operative preparation of the patient, so they are quite standard. We need to basically fully counsel the patient on the indication and the side effect of the treatment that they choose. And in terms of neoadjuvant hormone therapy, it still remains controversial. At this moment, the guidelines do not recommend its use outside of trial basis. But there are small series in level 2 evidence to support, in the phase 2 trial to support the use of abiraterone, where they see reduced BCI up to 4 years follow-up in patients who are given abiraterone and ADT for up to 8 months before radical prostatectomy. So the treatment option in terms of open, laparoscopic, and robot has been ranges ever since the robot was introduced. But as you can see, the final verdict, although there's only 2 RCT to address this question, and there's another meta-analysis based on these 2 RCT, there's no difference in oncological and functional outcome, no matter what you choose, whether you do an open, you do a chopstick operation, or put in the sexy robots. But there is difference in terms of perioperative blood loss and the hospital stay, catheter length, and bladder neck stenosis, and favor the robotic approach. But I think the train has left the station. There's no need to discuss because now what happened? 90% of the radical prostatectomy in US and Europe will have been conducted by a robotic means. Left about 10% left for the open surgeon and the laparoscopic surgeon. So it looks like it's irreversible despite the expensive cost of incurred by using the robots. So many have voted the robot in their own prostate, including the 2 prime ministers from Singapore. So the task is already set. Okay. So in terms of intraoperative complication, it favors a robotic approach compared to open as well as laparoscopic. It has a much lower surgical complication in terms of blood loss, bladder neck contracture, etc. The oncological outcome of radical prostatectomy has been shown in 3 randomized control trials. As you can see, it involved low risk and intermediate risk disease, and basically over the various decade, from pre-PSA, early PSA until a screen population, which we see the HEM Protect trial, the cancer-specific survival has increased over the years. Now, if you choose to do a robotic approach, like what we are, most of the prostate cancer patients will want it to be done this way, in this day, then there are ways that you can do it. And I will share you with some slides. A patient who have undergone a PURP for BPH, 60 grams about a year ago, subsequently PSA failed to drop and have a biopsy repeated, which show a Gleason 4+5 cancer at the apex of the prostate. So this is considered a difficult case, and the prostate is soft, and this is the bladder neck, and we will move on. And after identify the bladder neck, then you open up the bladder, and you can see there are 2 areas of different mucosa color. One is white color, which is on top at the near to the catheter at the upper edge of the slide, and the other one is the pinkish bladder mucosa, and you can see the residual prostate loops is there, and the patient has been pre-stented to protect the ureter, and the robot is moved in as a manipulator by the surgeon at the console, from the console. So the bladder neck is dissected, and then the seminal vesicle will be dissected. Now, what I want to highlight here is not the surgical step, but I want to show you. You can see the robotic instrument is very steady. There is no shakiness, there is no tremor from the surgeon. Whereas you can see the laparoscopic instrument that is used to assist the operation itself is not so steady. So in other words, robot provide a steady platform for the surgeon to operate, and also provide a 3D high definition view for the patient surgeon to complete the operation in a more precise manner. And blood loss is minimum, as you can see, as compared to you do not have your hand in, you use a miniature instrument and you operate in a magnified view. So that itself translates better surgical outcome, but sadly not oncological outcome, because you do the same operation what you want to do with the open surgery anyway. So DVC you control, and this is the part where you have a maximum bleeding. Most of the time when you do open surgery, you need to put stitch, but you can see with the robots, this is the area that you can really control the bleeding well, and then you can see and actually fine-tune your dissection by angulate the scissor in a different direction. So this is just to increase the interest on the surgical aspect of the prostatectomy. And then we come to the urethra part. You can see in this particular patient, actually, you can very clearly see the urethra and every single individual vessel that you can cut and control the bleeding. So then you reconstruct and you join back. And there's a final specimen from post-TURP prostatectomy specimen with the two seminal vesicle, you can see, like octopus lips, tentacle. So 3 weeks after prostatectomy, the patient have a cystoscopy done to remove the stent. You can see as they go to. Sorry for the poor image from the. I think this is done in probably with a very old scope. But anyway, this is the sphincter. The surgeon intentionally slowed down. So sphincter is preserved, patient is continence, and then you can see straight away you enter the bladder neck, and then you'll be able to see the stent shot. Now, how about radiation treatment? Radiation treatment has equivalent oncological and cancer control as well as survival data as for prostatectomy. There's no level 1 evidence to directly compare each of the PROTECT trial where it show equivalent cancer outcome in low risk disease. So radiation treatment can be delivered in many forms. Mainly is the external beam radiation treatment, EBRT. And delivered in either IM, RT, or VMAT, or IGRT manner, or tomotherapy, which is better. But we don't need to go into this detail, but I just roughly need to know that they are using high dose now, up to 74 gray. And hypofraction is a trend and should be the next standard of care because it reduces the treatment duration from 35 days to about 20 days. And if you use the ultra hypofraction, you can even reduce it to 1 week. But you must have added IGRT and SBRT to complement the treatment dose because hypofraction means you deliver a very high dose of radiation, usually double the original dose, to the prostate over a longer period of time in a single day. Whereas brachytherapy, well, it's falling out of favor, but currently it's only reserved for low-risk disease who can very well be treated with active surveillance. So the use of ADT during radiotherapy is something that I think you all may find useful to know, is that ADT improves the survival compared to no ADT, especially for high-risk patient. For high-risk patient, the patient need to receive up to 3 years of ADT, minimum is 18 months. Whereas for intermediate risk, we can use 6 months. Low-risk patient who choose radiation treatment shouldn't receive ADT. And I think for ADT, you can choose the negalytics or LHRH agonists. There's no specific differences in terms of complication beside the delivery mode in between these two ADT mode manner. In terms of monitoring, any patient who under active surveillance post-prostatectomy or post-radiotherapy will require PSA surveillance, as well as check their urinary function recovery, as well as sexual function recovery. So in terms of staging, imaging, then you need to actually look at the reason why you want to do a further imaging patient post-op. Typically because of biochemical recurrence. And then when are you going to do it? That's a big topic by itself, but I will just highlight to you in the next 1 or 2 slides to tell you why you do a CT and bone scan, the yield is so low in the patient with a PSA of 0.2 or 0.4. You almost guarantee will not find anything. So you will have better bang on your money by ordering a gallium 68 PSMA PET CT. Unfortunately, this can only be done in IKN or in a couple of the private centers in Kuala Lumpur at this moment, or Penang. So PSA recurrence is considered as a recurrence of disease, meaning that treatment failure by the single modality treatment. So we have a various definition, as you can see, I have listed down there. Basically, the cutoff is using a 0.4. Some use 0.2 for the ultra-sensitive PSA. So what is the importance of detecting PSA after a patient have a radical prostatectomy and a rising PSA? So that cell means that there's prostate cell somewhere in the patient body. Yeah. So that cell is usually patient will get very anxious and very depressed with this value because they know the cancer is coming back. So that is what it means to the patient PCR. So, but is that so? So I think BCR have been looked at very thoroughly, and EAU had do a comprehensive review, and in fact I think it sponsored a systemic review by some of their researchers to look at the post-BCR in the post-RP and post-radical radiotherapy manner. to look at three important oncological endpoints, meaning that distant metastasis, cancer-specific survival or mortality, and overall mortality. So they find that BCR has an important in these three aspects. In particular, the doubling time of the BCR and how early BCR happens. Within 1 year is bad. Doubling faster is also bad. That is more important than the absolute value. And also the primary pathology of the cancer, if you have reason 4 or 5, that means the patient also will have an unfavorable outcome in terms of the three cancer oncology measures. So they categorize them into two risk groups: low risk BCR low risk group and the BCR high risk group, according to the EAU. So in terms of metastatic free survival, you can see the one in orange is the low risk, whereas the blue is in the high risk group. There is clear separation of curve as early as 6 months. Whereas in terms of survival, cancer-specific survival, the curve separation will be identifiable at about probably around 3 to 4 years time. So important to identify these two features. So the treatment is in summary, I think I come to the end of my talk is that most important, I think, is this slide. How do you choose which one for treatment option for which patient? Basically, you risk stratify them, and then you choose between active surveillance, radical prostatectomy, or IMRT according to the risk group. And between RP and RP, the choice is the patients want to make, because they will want to know all the complications. If the patient cannot accept any urinary incontinence, they will be better off to go for radiation treatment. Whereas the patient have a lot of bowel symptoms, or maybe you have a rectal problems and irritable bowel disease, then those patients may be better off to undergo a prostatectomy, because the bowel symptom is quite dominant side effect for patient after radiation treatment. So, in fact, ladies and gentlemen, I have presented to you in summary is we need to define the patient fitness and life expectancy in managing patients with early prostate cancer, taking into consideration their urinary and sexual function, as well as what is most important to them in terms of their life, their quality of life. And active surveillance is certainly a preferred treatment, and it's not not doing anything. It's actively doing something just to defer treatment until such time that treatment means imminent. So BCR doesn't mean imminent death. There are many treatment options available, and when to treat, I think further stratification of the risk is helpful for us to decide who should receive further treatment. Thank you.